And thank you. And we'll begin. Well, welcome everyone to today's Community Grand Rounds. My name is Mark Carroll. It's January the 14th, 2021. I had to think about that twice. And we're really pleased to have a session today on the emerging best practices for the use of monoclonal antibodies. We're joined today by a number of folks from different organizations. I won't introduce them up front, but as each person does a presentation and a brief summary of what they're doing and what they've learned from monoclonal antibodies, I'll do a brief intro, but I invite all my panelists to correct me in my introduction and also correct me if I mispronounce anyone's names. And I apologize for that in advance. This topic is super timely. A couple of just ground rules for today. The first is this is an emphasis on our learning and celebrating all the positive work that's been going on. And so right up front, I want to thank everyone who has been building systems to deliver monoclonal antibodies for eligible high-risk patients and community members in Arizona. Big shout of applause, a lot of hard work, and I really appreciate that work. We all want to acknowledge that, and we're thankful for your willingness to join us today and share some of your lessons learned. For everyone's purposes, today there'll be just brief summaries, 5, 6, 7 minutes of what each organization has been learning. So we're so appreciative of people taking the time to share that with us. For those attending today's session, please share questions in the Q&A or chat, and we'll try to get to them as best we can. And I'm encouraging the panelists and presenters, please feel free to ask each other questions at the end of each presentation. We'll all try to keep on mute when we're not talking if we can, but if that doesn't work, we'll just fix that as we go. And I think we're ready to turn it over to our first presenter today, Dr. Jason Brown. Jason is the CMO for the pharmacy division, among other hats at Banner Health. And Jason, floor is yours. Thank you.
Thanks. Can you see my screen here?
Not yet.
Go ahead and click the green share screen at the bottom, and then click on your PowerPoint.
Yep.
It might take a second. There we go.
See it?
Yeah, got it.
Got it. Thanks, Jason.
Okay. So I just appreciate you all convening today and giving me the opportunity to chat, and hopefully I'll learn from some other folks some of the things that have been going on. So my name's Dr. Jason Brown. I'm the Chief Medical Officer for Banner Pharmacy Services, which is the pharmacy division for Banner Health. I also am the Chief Medical Officer for Banner Health Transfer Services that coordinates transfers and both of our transfer centers in Arizona and Colorado. So for monoclonal antibodies, I'm going to hit on really three themes. Number one, what delivery models have we instituted? What are the challenges that we've encountered, and what are the innovative solutions that we've put in place? So I put on there in the upper right-hand corner, 737 is the number of monoclonal antibody infusions that we've infused in Arizona within Banner Health. And then 2 times in the upper left-hand corner, we've steadily increased the numbers week over week, and definitely are really rapidly increasing that number. We did twice as many infusions last week as the week prior, which is awesome. But we've learned a lot, and again, like I said, eager to learn more to try to how to make it even go better. But we essentially have 3 different types of care delivery models. I would call it one being a hub and spoke, one being a respiratory clinic or infusion center model, and one being the emergency department model. So I'll first touch on the hub and spoke model. So this is when we include our Banner urgent cares, our ambulatory medical groups, and our Banner emergency departments. So we don't have, we have very limited rapid COVID testing, which is really limiting our ability to speed up this process and to get patients enrolled in this monoclonal antibody testing. So our hub and spoke model is when a patient walks into our Banner urgent care, they're evaluated by the provider, they get their COVID PCR test, they leave and they have to wait at least 24 hours or so. And then what happens is the lab tests go to a centralized call team, and then they call them back with a positive test, and we have now a centralized PharmD that will get them coordinated to get into one of the infusion centers. That same process happens for our primary care, our employed primary care physicians, and then that's a similar process happens with our banner emergency departments. If you show up to one of the departments, they'll do the rapid test, positive test, or get called back. Here's some lessons that we've learned just from this hub and spoke model. It was initially, we already had initial centralized call team for positive tests stood up. So actually what we did, we just piggybacked onto that, and we added PharmDs to that team. So the PharmDs would then call the patient with a positive test and say, hey guys, are you interested in this treatment of monoclonal antibody? If so, we'll talk about the fact sheet. We'll get the orders sent over back to the ED medical director, have them sign it, and then send those to the outpatient infusion center. That's kind of a clunky process. So what we've done to improve that is we've actually leveraged our electronic health record. We have Cerner, and so what happens now, went live a couple weeks ago, 2 weeks ago now, is that on the front end, if a patient comes into our ED and the ED doc knows they're going to be discharged from the ED with possible COVID, they're going to do a COVID test. What they'll do is we've created an order set in Cerner to where they essentially write kind of future orders or pending orders, so that and they talk about it up front to say, hey, this is a potential treatment. Would you be interested in receiving the monoclonal antibody? And if so, then they'll go ahead and complete those order sets. That way, when it goes, the orders are already there. When they'll discharge the patient, when the centralized PharmD gets that positive lab test, number one, the orders are already present. Number two, we know the patient's interested because the provider already had that conversation. And number three, they're not paper orders; they're electronics. The infusion will have them. So that's so we have now implemented that 2 weeks ago in our EDs. We went live with that electronic process yesterday in our urgent cares. And so that's one of the things that we've done. The other care model is a respiratory clinic infusion center model, to where we have essentially it's like a sick clinic, to where patients can come in the front door and they get all of that in the clinic, and also receive referrals from the community. And then, as I alluded to earlier, the emergency department model, we have very limited rapid COVID testing. And so we selected one specific ED to pilot, where patients who come into the ED and we know are high risk. Again, we leveraged our electronic health record because we have such limited testing. If we know they're going to go home, if we know they meet the risk factors and they're willing to stay in the ED for the infusion, then we'll do a rapid COVID test. If it's positive, then they'll get infused right there and sent home. Here are some of the challenges that we've had is, again, my biggest thing today is testing. Rapid COVID testing would help alleviate a lot of the challenges that we're experiencing operationally. The challenges are coordination of the infusion depend on the infusions, because it's depending on the turnaround time of the COVID PCR tests. Again, the ED capacity or surge, that's where we're piloting it in one specific ED, just to make sure that we're already having capacity issues with the surge. That was an issue. And then from the outpatient infusion center side, they typically infuse oncology patients. So operationalizing a separate entrance or space. And then from an ambulatory side, all PCPs, a lot of them aren't used to working with outpatient infusion centers. So it's learning that process and educating them to the medication and what that process is. Also, limited portals of entry into health systems for evaluation and treatment. What I mean by that, early on in the pandemic, some ambulatory offices would not see possible COVID patients. So you had that kind of issue as well. We have there are some community physicians that are working remote. So when you try to sign orders, that can sometimes be an issue as well. And then coordinating patient scheduling. Some patients these days, not answering their phones, they operate by text messages instead. And then infusion center hours, Monday through Friday is normal, and a few hours on the weekend, but that was a barrier as well. And then helping patients understand they need to get tested quickly because of that prolonged turnaround time for the test, and then getting them scheduled. Real quick, I know I'm almost out of time. For innovative solutions, we did the pilot in the ED. We added that PharmD to the centralized callback team. We essentially front-loaded the discussion points with the ED providers and leveraged the electronic health record in our EDs and our urgent cares to optimize that workflow. We're now operating our infusion centers 7 days a week. And then we also, from a policy perspective, we are now allowing, we had to update a policy around monoclonal antibodies to allow our nurse, to allow like what we call non-purple badge nurses, but our nurses can now, our nurses can infuse monoclonal antibodies without having to have that type of oncology type of certification. And then the discussion around monoclonal antibodies and who can actually order it. Is it physicians, nurse practitioners, and PAs? Initially, we said only physicians can. We met today. We said now we are expanding that to nurse practitioners because they're independently licensed, and it is we have to keep in mind it is under an emergency use authorization. And then from a consumer-friendly perspective, at bannerhealth.com, one of our landing pages, we stood up and specifically for monoclonal antibodies. One's for patients, one's for providers. And we did that a few weeks ago, and we've had several iterations based on feedback to educate patients and physicians around that. So I'll stop there. I probably went over. That's what we've done.
No, that's great. Boy, you squeezed a lot of important information in there. I'd like to introduce Dr. John Redd. John's the Chief Medical Officer for the Health and Human Services Assistant Secretary of Preparedness and Responses Office. John, I hope I got that right. Thanks for joining. You're in the state with us now. I'd like to invite you to ask any questions as we go along, and encourage all the other panelists and participants to send in questions. But panelists, if you have any brief questions for Dr. Brown, please go ahead. But John, welcome. Thanks for joining us.
Thanks very much, Mark. I just want to say hi to everybody. Mark and I know each other. I'm an IHS alumnus, so once an IHS, always an IHS. And I'm currently the Chief Medical Officer at ASPR, and it's been our job to.
John, your sound is a little down. When you came off the headset, I think we can hear you, but it's a little faint.
Is that better?
Oh, that's tons better. Yeah.
Mike. All right, sorry. But no, what I was saying is that, Mark, that you and I know each other because I'm an IHS alumnus. And same way as I know Dr. McCauley. But anyway, I'm the Chief Medical Officer at ASPR, and at HHS, ASPR ended up with the job of distributing the therapeutics that have been newly developed by the government in an equitable fashion. So it fell to us to make sure and distribute things properly. So that's what we've been working on. And I'm happy just to take questions, or I can give the summary, Mark. Up to you.
If you're ready to do a summary, John, since we're connected to you, why don't you go ahead?
Great, cool. So bamlanivimab and then subsequently casirivimab and devimab, you can tell I say those a lot. Those both came out in November, and they came out under emergency use authorization, as we've mentioned. And what I wanted to mostly focus on, actually, let me share my screen, and I've got just a couple maps. This should be in preview, so let's see. I've got a security problem with Zoom. I'll just talk through it. So we initially, as you all probably remember from remdesivir, distributed solely through states. The point of that was that we've got a federal supply, and this comes, I've spent most of my career actually with CDC, which, as you know, is quite a state-centric organization, right? It's really viewed as federal support of state and local public health. And so we brought that experience to bear. And the initial allocations in states was done based upon a couple different data sources. And that was primarily hospitalizations as reported in HHS Protect, and also the total number of cases in a given state. But what happened was within, I'd say, probably 4 or 5 weeks of that, so middle of December, it was very clear that although if you look nationwide at the demand, that the products are actually scarce. In fact, they are not scarce in use because of difficulties with utilization. And the ethics change quite a bit between a condition of scarcity and non-scarcity. So that's why we've been so excited to work with 3 different sites. So that's El Centro, California, with Pima County, and initially Tucson Medical Center, and then with Sunrise Hospital in Las Vegas. We've had 3 federal projects with National Disaster Medical System personnel to prime the pump, essentially, in trying to demonstrate the usefulness of these products. And we've become very convinced, impressed about the ability to avoid hospitalization. So I'll tell you that with Indian Health Service, that was literally the first place I thought of as a demonstration site. So Indian Health Service was the first pilot that we developed for these products. And the reason was that there were several very positive things about IHS. The first is that IHS, of course, takes a systematic view. So the ability to avoid hospitalizations, I knew would make sense to anybody in Indian Health Service. And secondly, I've practiced at lots of remote locations with IHS, and the infrastructure to give these products is present all over the place, right? It's, as Jason was saying, once you get used to it, they're really not complicated to give. So, so that's how we ended up where we are. In terms of the overall numbers, I'll give you the summaries as of now. And this is as of yesterday, if you put bamlanivimab and casirivimab and imdevimab together, which we do because although one is a monoclonal and one is a combo of 2 monoclonals, we think that they are, the EUA is the same, and so far we think they're equally efficacious. So I want to say that officially. We do not have a preference for one, over the other. But so far, the federal government has been able to allocate 658,000 patient courses, of which just under 500,000 have been delivered. So the product is out there, and that's what I wanted to say. The utilization rate on a weekly basis is about 20% and increases every single week. So it's gone from 10% the first week, really monotonically up. So utilization is really increasing. We're really excited to get the product out there. I want to say something very definitively. The federal government, of course, as is appropriate, spent a lot of money on these products. They were acquired by the United States government on behalf of all Americans for everyone in the country. I cannot say that enough. We feel very deeply about the ethics of making sure that these products get out. And notice that I didn't say to make them available to citizens. What I said the other day on a big call was these products are to be made available to human beings with COVID-19. So in our sites, you don't need an ID to get in. I mean, I just want to say that again. They were procured on behalf of all of us for human beings in the United States with COVID. And I'll just leave it at that. All right. So thank you very much, Mark, for the intro, and I'll be happy to take questions.
Yeah, thanks so much. Really appreciate that. And thanks for being here today and for your leadership. You mentioned the work in Southern Arizona. So I'd like to invite Dr. Amy Biter. Amy, if I pronounced your last name incorrectly, please correct me. But I'd like to do a summary of some of the lessons learning your perspective at and you're muted right now. My panelists are looking, and I know that Amy signed it as someone else. Yeah, there you go. We
Yeah.
can hear you now. Thank you.
Okay, good. And Mark, I was having trouble hearing you for a short period of time, but it seems to have gotten better. So I am signed in as Jennifer White. I cannot turn my camera on until I finish sharing my screen. I've had IT challenges
That's okay.
recently. So I am going to now, why can't I find it? Hold on one second.
That's okay.
Well,
While you're sharing your screen, I'll just note that and remind us all that we're here to learn. A lot of people are juggling a lot of things, and I, for one, can never find share screen when someone asks me to present. I should have brought the slides up for you. We can see it now. Thank you.
Yeah, okay, good. Thank you. I am Amy Biter. I am the Chief Medical Officer at Tucson Medical Center, and we have kind of had two experiences with administration of monoclonal antibody. The first one is we received our first shipment from the distributor November 16th, and we only received about 12 doses initially. So we were focused at that time on our employees and other healthcare workers, including physicians who met the high-risk criteria. So what we did was we developed a process to infuse patients who qualified and who were interested in our emergency room. We did that because the volume was low and because we really didn't have staff to administer anyplace else other than the emergency department. So it was cumbersome. It was myself and another physician, employee health would screen, and then we would talk to the employees and individuals about the drug and whether or not they were interested. We would schedule them in the emergency room at 6 and 8 in the morning when we tended to be the least busy. And we subsequently gave our first dose on December 6th. And we actually administered a total of 25 doses, not 15. And a couple things, no one else, I think Banner in Tucson, but no one else in Tucson was actually administering because of the logistics, the difficulty, the staffing. Nobody else could figure out how to do it. So I don't know, Jason, if Banner in Tucson received everybody else's doses, but people were giving us their monoclonal antibody doses. The biggest challenge was that it was cumbersome screening the employees, and it just became, I mean, even at 6 and 8 a.m. in the morning, the ER became so busy that they were challenged giving monoclonal antibody at that time anyway. One of the things we did do during that time is we have Epic, and we built the order set in Epic. So that was completed. And just as we were thinking we can't do this in the ER anymore, we don't have enough staff, but we got to find staff to administer in another area of the hospital. Just when we were about ready to open another location, then Dr. Red and his team came forward, and we are the beneficiaries of this collaborative effort with U.S. Health and Human Services. I think we were notified it was over the weekend that I found out about it, and we were up and running, I believe, by Wednesday. So within 3 days, we were up and running and infusing patients. So the HHS provided staff, the medication, lab kits, TMC provided, our EMR space, scheduling support. I'll talk a little bit about that. I'm going to skip over these two slides. And so just from a logistical standpoint, we opened up a closed unit that had 16 curtain bays. The unit was kind of at the end of the hospital on the first floor, so we were able to easily convert that to negative pressure. There was a door directly to the outside, and we got supplies, got the unit up and running within 3 days. We did, because the proximity to the ER, it's a couple-minute walk down the hall, but we did drills, performed dry runs, and really felt comfortable with getting up and running on Wednesday. HHS provided, I believe it was one pharmacist, one PA, I think several RNs, and then several medics to staff the unit. So one of the things that was interesting is if we didn't communicate, then we would have been, you know, infusing a very small population of patients. We really made the effort to communicate widely outside of our own medical group, outside of the ED, and to communities, including 2 federally qualified health centers. So we did that by calling them and sending a letter from me directly to those large PCP practices, including the 2 FQHCs. We shared this on our daily physician communication daily for several days. I think HHS was really good about working with us to procure local news coverage and press releases. So I will say within 24 hours, I was getting calls from community physicians continuously. We actually ended up developing an order form for those physicians that are not on Epic. And you can see that right here. I've just copied and pasted the order form for physicians who are not on Epic. They fax the order in, and we have to date then, as of today, we've gone over 200 patients in just about a week through this process. The challenges, you know, mainly, really it's very seamless. I would say the biggest challenge is that I think there's a lot more than 200 people out there who would benefit from this. And to the degree that we're able to continue this after HHS leaves next week, I think it can only help the community. There are so many more patients out there who I think would benefit.
Yeah, I think that's just an excellent point. And you hit on some key themes. And I have to say, just impressive work to get to 200 over the span of a week at this newer location that you've just opened up. That's pretty impressive given everything that's going on. You know, it's important for us, I'll probably say this 3 or 4 times today, to remind ourselves that y'all are in the health systems that are taking care of sick people in the hospitals. So finding staff, finding ways of doing this, and the learning that you're sharing is really impressive. And while we know there are more folks out there and we want to reach them, we need to celebrate those successes and really acknowledge that those 194 folks got timely care, and hopefully most of them will stay out of the hospital. Does anyone have any questions for Dr. Biter?
Yeah, it's Dr. Brown. So great presentation. Just you posed a question there. Yes, Banner is offering the monoclonal antibodies at the Abrams Clinic there. I know Dr. Mathias is on this call. She's done a phenomenal job, and we're seeing some really good results in the work that she's done there within the Abrams Clinic. So I did have some questions around your ED process. Do you all have rapid testing in the TMC ED?
We do. We do. It's we brought that up probably just before the holidays.
Okay, yeah, that's what I've noticed is like it really helps if because we don't. Let's just say it's just very limited supply throughout. That's I think if we can get more rapid testing, that's will resolve a lot of the operation.
Yeah.
Yeah.
And so I always say that rapid testing is relative. By rapid testing, I'm referring to antigen testing, which we get the results in about a half hour. We also have PCR with a turnaround of about 2 to 3 hours. But we're for patients who we think may benefit or who may need to be admitted, we're using antigen testing. And then if it's negative, we're confirmed with a PCR.
Yeah. I'm just interested to learn with your community providers filling out that form. They're just faxing it to the ED, the orders. Is that how that's working, or?
Yeah, good question. Because we're not using the ED anymore, since we've changed to the new unit, we are not using the ED. They are faxing it to, it's actually an adjacent staffed lab. It's a GI lab that we're faxing those to now, when they're communicating with the folks with HHS, and getting those patients scheduled.
Great. Hey, I'm going to keep moving us forward for sharing from other folks, but great insights, fantastic work. For folks just to know who aren't aware, that was Dr. Amy Biter, who's the Chief Medical Officer of Tucson Medical Center, who was sharing, connected and under someone else's name. So thanks so much for doing that, Amy. Dr. Red, thanks for commenting about the delay of the second dose of the vaccine for 90 days after someone's received monoclonals. I'm going to jump across the state over to the northwestern portion to Kingman Regional Medical Center and ask Dr. John Ashurst to give us a summary of how things have been going there. John?
Yeah, hey, so yeah, I'm up at Kingman. I'm one of the ER doctors. I'm actually going to pull up my screen here to show some data that we have. So this is our data right now. So a little bit about everything that we're doing. So we do have the two models. We have the infusion clinic as well as doses can be given in the ER. We try to not give doses in the ER if at all that we can because of the volumes and our current holds. So we try to get every dose that we can at our outpatient infusion area. And the way that it kind of works is it's a unique model. Basically, all the outpatient tests that we do at Kingman end up coming to me to look at. And I then screen all of the patients to see if they meet the inclusion criteria to receive the monoclonals. After they meet the inclusion criteria, I then call all the patients and then get them an appointment. Some of the issues that we've had with it is we're not the only place in Kingman that does tests. So we do, there is the college doing tests, the county's doing tests. There's a couple other urgent cares that are doing tests. So those patients I would never know about. And one of the things that we're seeing actually is because of what we're doing, and because we've given a large number of the doses, is now it's a lot of the outpatient providers will call me and say, hey, I have a person who tested at our county clinic that's positive, can you give them a call? Or they tested at our community college, can you give them a call? So that was the major issue. One of the other issues that we also have is that the onset of time to them getting a test, even though at our place, whenever you are seen, we can get you in for a test usually that day or the next day. However, what we're seeing is that patients are waiting 6 days to end up calling in 7 days, 8 days. So that is one of the other issues that we're seeing. At our outpatient infusion clinic, we have given probably more than this number and here, this 145. This week alone, that number is probably now pushing 165. And from our data, what we are seeing is that a small percentage of people after infusion are being admitted to the hospital. So that is the good thing. And then when they are admitted to the hospital, it is only for a very short time. So that is the major differences. And also there's a decreased population that's being seen in the ER also. So it's cutting back on utilization of other healthcare in our area.
Wow, that's impressive. That 4% figure is something I think, John, you and I heard from some other institutions around the country showing how effective this is. And it just goes to show that if you take one person and have all the data come through them and you don't let that person sleep like you, Dr. Ashurst, maybe there's there's a way of creating efficiencies. Obviously, that's really challenging, but thanks for that summary.
Yep.
Any questions for Dr. Ashurst and the great work that's going on at Kingman? And Dr. Biter, it's great to see you on camera. I'm glad you got that sorted. Thank you for joining.
Got it to work.
Thank you so much. Hey, can I turn now to Northern Arizona Healthcare and Drs. Cortez and Mujin? Jen, did you want to go next and share a perspective?
Sure, I'll get started here. I think I'm going to just sort of focus on a lot of the things that other people have kind of already touched on. Essentially our challenges have standing up this whole process have been finding the space and the staffing to do it. We're currently using ED nurses to staff our FMC site, and we just stood up our VVMC site today, and they're pulling from wherever they can find people. So it's not consistent, and we are concerned that if we have to pull that staff to deal with inpatients, that we won't be able to provide the service. So that's an ongoing thing that we worry about. In terms of our referral process and how we're trying to capture people, we're doing, I think, similar things to what other people are doing. In our ED, we do use antigen tests. We've run out every single week of our in-house tests. We reserve those only for patients that require urgent OR procedures or are getting hospitalized and that kind of thing. So patients who would be candidates for bamlanivimab essentially don't really meet criteria for our PCR test. So we'll do an antigen test. If it's positive, those people, if they're willing and able to stay and meet criteria, are able to get infusion in the ED. It is not preferred because the ED is busy and often housing inpatients and all those other things. So it's a challenge. If they don't feel that either, like if the patient doesn't want to get it done at that time, or if the provider or the staffing doesn't allow them to provide the service at that time, they'll do essentially a referral to get them scheduled into the regular clinic then soon thereafter, and that's arranged by our outpatient case managers. In addition, if we have a negative antigen test, those automatically get sent for send out PCR. Our outpatient case management team calls those outpatient PCRs if they're positive, and then they go through kind of their standard script about isolation and how to take care of yourself and protect yourself. And then if the ED has documented that this person is a candidate for bamlanivimab, they'll go through that discussion as well. And if the patient wants to participate, receive that medication, then they'll kind of put them through our other process, which is where they get a telemedicine visit. They go through the whole EUA, make sure the patient meets criteria, essentially evaluate them, and then they'll get scheduled for the infusion. And so that's similar to our outpatient referral process. So I'll pull this up after I talk and show you guys what it looks like. But essentially, we have an outpatient, and I'm sorry I have to walk because my computer's gonna run out of batteries. But we have an outpatient process where, sorry about that.
That's all right. We're with you, Jen. It's fine.
Where anybody pretty much can refer. So we'll take outside community referrals, and our own outpatient providers can refer. There's a standard form that they fill out, and then our case managers call them back. They schedule them simultaneously for a telemedicine visit and an infusion. At the telemedicine visit, the providers will enter the orders. We also use Cerner, so there's an order set that has, the bamlanivimab order, and then also like an anaphylaxis order set, so they can use that right away if necessary. And so that's sort of like the second way that people are referred. What we're working on right now, trying to capture, are essentially people without primary care providers and who may not have the same kind of medical literacy as other people, which has been a big challenge in our county. Most of the testing is done through the county, and those patients that get positive tests may not ever come into contact with any provider or their primary care provider, because a lot of the providers aren't even seeing sick patients right now necessarily, or they're, it's a different process and there may be delays. So Dr. Mujan has been working with the county on trying to figure out how to get them to educate people when they call and tell them about their positive test results, to make sure they know that this treatment exists, and we're trying to figure out how to bring those people into the fold. In addition, we're trying to make sure it's more obvious to people who don't have a provider that will still see you. Just call. You don't need anything, we'll get you in with one of our telemedicine visits and get you in for treatment. We do offer, the same financial assistance we would offer anybody walking into our emergency department if they needed it. And we're just trying to figure out how to educate on that, because I don't think that we have been able to get as many people referred or treated as some of these other sites. We're up to 42 doses. 6 of those have been given in our ED. The rest of them have been given in the outpatient infusion. That does not include 10 doses that we sent to a long-term care facility that was having an outbreak essentially in their population, most of whom are quite elderly and all of whom met criteria. And so they struggled a little bit as well with the whole 10-day time period. And so we weren't able to treat everyone there, but we did give them 10 doses, and then they administered the doses themselves on site, and we provided them with sort of the guidance on how to do that.
Jen, I think that point is so important, and I know a number of you have been doing that with some community facilities and are working on processes. I know Dr. Jackson and folks at Honor, and maybe Jay, you'll speak to that and what Mayo is doing. I think that's one of our learning opportunities moving forward as well. Jen, I didn't mean to cut you off. Do you or John, anything else that you'd like to add? Or
I think that's the big thing that we learned with our experience there, is that a lot of these patients in skilled nursing are old and frail, and if these people couldn't travel 100 miles to come get the treatment here, so bringing it to them was pretty critical, and I think that's something we should focus on, especially with these congregate settings. If we can deliver this to them, it may prevent a lot of hospitalizations in that high-risk group.
And I just wanted to point out, we had trouble with peds. That's the one piece we don't have consistent staffing that's comfortable with managing pediatric related emergencies and that type of thing. So we have not consistently offered the service. We had one patient kind of slip through the cracks, and the people that were on that day felt comfortable with it, so we allowed it to go forward. But the pediatric piece, we don't feel like we can consistently offer that service.
Yeah, understood. Hey, Dr. Red, you had a couple of thoughts, I think.
Yes. Yeah, thanks very much, Jen. I just want to say a couple things about reimbursement. I mean, obviously, none of us are in this for the money, right? Neither are institutions, but it has to be a sustainable service. And I wanted to mention a couple things to pick up on what Jen said. So the first is telemedicine is a great idea for the first visit. And that's billable under Medicare, and then because of Medicare, other providers. And the second is regarding long-term care facilities. Those are all billable for the reimbursement for infusion, which is $309. Now that's not a lot of money, and it's too little. We found, we've worked a lot with CMS on this, let me say, about trying to get things reimbursed. On a one-by-one patient, literally in their home basis, that doesn't add up. However, it does add up in congregate settings. So I would just encourage you all to use the flexibilities that CMS has built in. They didn't increase the amount of money, the $309, but they have put in every possible flexibility in terms of place and type of delivery. Thanks.
Yeah, thanks, John. Great point. Hey, I'm going to swing the presentation podium virtually to the central part of the state. I got a few folks on from different organizations, and Northern Healthcare in Canaan, Regional Medical Center. Dr. Salinas, would like to connect from Mayo Clinic. Thanks so much. And Jay, you may still be muted. Look for your unmute button.
All right.
There you go. Got it.
Can you see my screen? Not yet, probably.
We saw it, and then it shifted off. So I think I
Got it,
distracted.
right here.
There it is. There it
Okay,
is.
perfect. So again, thank you for the opportunity for this sharing. My name is Jay Meningo Salinas. I'm the nurse administrator for hematology, oncology, and the infusion centers at Mayo Clinic. I know that Dr. Orenstein, who is our chair of the Division of Infectious Diseases, is somewhere in our participant panel there, and the participants. And then Dr. Shapatel has been in contact with, I think, majority of the group as the CMOs have been meeting. So just move on to the next slide. Want to introduce to you guys the different locations and sites that we've been infusing the MAB. So really the first one there is our primary site, and it's, we instituted this on December 7th, so just a little bit over a month ago was when we stood this up. And really later on, maybe the next slide, you'll see how innovative this is. So it's open, it's 2 chairs. We can see anywhere between 8 to 12 patients per day, actually 8 patients a day, 12 on Saturdays and Sundays. We are following the Operation Warp Speed guidelines. So we use the waiting room model for this. So essentially the patient is in the chair for 1 hour. After they're done with the treatment, they are in the waiting room, AKA tent, for another hour to be monitored before they can be discharged, where they're assessed by the nurse before they're discharged. It's open 7 days a week, 7 to 5:30, last patient being 2:45. We considered to extend our hours a little bit longer, but it got dark in the parking lot, so we really want to make sure that patients were safe as they were leaving their treatment, so we kept it that way, and we are okay with that. As of last weekend, after the Christmas holidays, we were really seeing a lot of a growth in the number of patients that were eligible for the MAP treatment, so we were able to partner up with our pulmonary practice partner group, and they were able to give us 4 pulmonary exam room that was directly adjacent to our infusion clinic. So it was nice for staffing efficiencies, workflows, pharmacy. And that one we're able to see just on Saturdays and Sundays up to 16 patients per day. And it's a traditional model because we don't have a waiting room in there, and besides it's a public area. So it's a traditional model where the patient is there in the chair for 2 hours, 1 hour for the infusion, another hour for the monitoring. Effective January 25th, so while this is all happening, we have been converting the old vacated space in the Scottsdale clinic, where there's an old RADONC space that was vacated in April. We've been converting that. Construction guys have been working fast and furious in that one. Where that will have 10 chairs and capable of handling 30 patients per day on a traditional model, 50 patients per day. We can push it to 70 with the waiting room model if we really need to. And that one will only be open Monday to Friday, again, 7 to 5:30, because we don't have many of our other resources there when we are there. This is our infusion clinic. It's an RV. It's an RV. When you need space and space is available, you do it. So this RV was in the parking space for 6 years as our mobile research unit. We took it out of the parking storage and drove it into the Mayo Clinic parking lot and put it into commission. So as you can see, the RV is right there. We've got, what you don't see is a ramp, because we need a ramp for emergency purposes, and also with patients that can't go up the stairs. This is the PPE tent where nurses change. There is another tent right beside it, which I don't have a photo, couldn't fit it all here, where we use as the waiting room, monitoring space for patients after they're infused. So 1 hour inside the RV and then 1 hour inside the tent for monitoring. On the right-hand side is the picture of what the RV looks like. It's fully equipped. We've got data monitoring. We've got our recliners in there and everything to treat the patients. I got permission to use this. This is one of our early patients when we stood up the clinic. You can see this is the other chair that's towards the driver's side. So there's a chair in the back, there's a chair in the front. This is the patient right there. And in between the RV, you can see the work area for the staff that is in there. Our volume to date, again, since we stood this up on December 7th, we have seen 295 patients in the space, again, fully maximizing our efficiencies there. The spike that you see where there's 17 and 16 patients, that was with the use of the pulmonary exam rooms in addition to the RV. So we filled up our capacity in the RV. We overflowed into the exam room. We're going to be doing that again on Saturday and Sunday this coming week until we move into our 10-bay space in the Scottsdale clinic. One of the greatest efficiencies that we've really gained in our process is working through Epic. So essentially in the Epic report, we are able to create a scoring system. So in here, where this is very colorful, you can see where it says mass score and a COVID-19 score. So essentially, every single patient that is tested at Mayo Clinic and comes up as positive, if they have a medical record number at Mayo, they automatically end up on this report that our Epic gurus created for us, and it scores the patients based on the EUA criteria that was created. It gives them a score. So essentially, the higher the score, the more the patient is qualified to, or candidate to be a recipient of MAB. This report is generated every day, and it is the foundation of our selection committee every evening. We have a selection committee that meets from 5 to 6 p.m. It's comprised of our ID physicians, a couple of administrators, a member of the infusion department, I included, we rotate through that, pharmacy as well. And again, we look to the mass score here. So the mass score is really the first score we look at, because it was, again, developed for who meets the MAB therapy. And then we crosswalk it with the COVID-19 score as sort of the tiebreaker for patients. So we sort by mass first, and then if the mass is high but COVID-19 is low, we open up the chart and review it. So essentially, you might be wondering, how does the scoring work? Sorry about the BAS. We initially created this for bavdelimumab only, but now it's that. So essentially, we mine the patient's medical record, those who are COVID positive, that was tested at Mayo Clinic and has an MRN, we mine that data. If they come up at their age 65, they get automatically 1 point. They have diabetes 1 point, BMI, it goes down. So that's what comprises the BAS score. The COVID-19 score, which is the next column, these are the different points that the patients get, which again adds up to their score, and which the patient, so if the scores then determine who is eligible and has highest risk. So that has been really efficient as we review our patient list or COVID positive list at the end of every day. I'm not going to go through this, but essentially what happens to that list is that our COVID-19 infectious disease nurses make phone calls to the patients who the selection committee deemed as eligible, and then the patient is then put into the schedule within the next 7 days. That's our criteria. We've seen that the sooner that we can give this to the patient, the better. And then they're scheduled into our calendars, into the RV or into the pulmonary space, and they come in. So again, I'm not going to go through that everybody has their own workflows. And then the other efficiencies we've gained is by the use of nurse-initiated protocols, which again, it's the protocols that does not require provider to order to initiate, but rather are based on a very defined patient population, inclusion-exclusion criteria, if-then criteria. This is used for vaccinations, and so this is what we use in order for us to expedite the treatment of patients. So I want to be respectful of everybody's time. So yeah, any questions with that at all?
Oh, that's fantastic. Someone had a question, I think. I'm sorry.
Yeah. Oh, and I see Dr. Orenstein is there too, so he can type.
Yeah, thank you for the Q&A that's going on, and thank you for the help answering some of those questions in the chat for folks. By the way, big shout out to White River. Thank you for your chat earlier about all the work you're doing there. Any questions though for Jay and the folks at Mayo?
Hey, it's Jason Brown. Just a great presentation. I work at Banner. I'm just curious. Two things. I'm interested more in the mobile unit concept and on the front end, the operational process. How are those? Like, how do you get into? How do the orders get sent? Are those patients that were seen in your ED and in primary care? That's my first question. And then the second is about the nurse-initiated protocol.
Yeah, so yes, on all fronts, these are patients who were either seen in primary care and then had symptoms and then sent to the tent to be tested, or the patients are admitted to or came to the ED, tested positive, and we don't infuse BAM or the MABs in the ED just because we don't have the space for it. So then the patient is discharged, and then they come up in the list that I showed you, our EPIC list, and then they are then called to if they're eligible. They're reviewed first, and then if they're called, if they're eligible.
Yeah, sorry. My question is more along the lines of, if I'm a community doc in Scottsdale, a PCP, how do I how do I enter into how do I fax my orders to the mobile clinic? That's
right.
what I'm.
No, and that is a good question, because right now these are only Mayo Clinic patients. They have Mayo Clinic MRNs. Yep.
Got it. Okay. Thank you.
Great questions. And obviously we're identifying opportunities to grow, but again, really want to celebrate all the learning. By the way, Jay, that's not an RV. That's a stationary mobile healthcare delivery system. So
it's awesome. Yeah, I know.
Hey, we
had some raised eyebrows when patients park in the car, or park their car, and like, okay, but we've got a lot of thank you cards, so we're happy with it.
It's great. It's very well done. Thanks for that work. In summary, I'm going to turn to Dr. Bloomquist from Phoenix Area Indian Health Service. I know our time's a little tight. I hope everyone can give us a few minutes after one. Dr. Bloomquist, take it over. Really appreciate it. And you're on mute. If I was quick, I could unmute you, but there you go.
All right. So, trying to share my screen here.
Hey, while you're doing that, if folks are listening and you've had some experiences and you want to share some of that with me, I'll help work with the right people in the state to try to aggregate people's perspectives and learning moving forward. Take it away, Paul.
All right. This is Paul Bloomquist at the Phoenix Indian Medical Center, and we've had our experience has been gradually building. What we found, we first were notified that we were going to receive bamlanivimab, and we thought this was going to be a very scarce resource. So our first concern was, how do we get this equitably distributed? And so we looked at the EUA and the use criteria, and then we looked at the Blaze 1 study, and we decided on use criteria that were more consistent with the study than were with the EUA, in order to provide the medicine to people who were most likely to benefit from it. It didn't take long to figure out that we needed to loosen the criteria, or we were going to have a hard time getting the medicine out to people. Our process here, it really involves the public health nurses who are reviewing the previous day's positive COVID tests and notifying the patients of their results. And that was our biggest referral source. We worked hard to get primary care providers in the emergency department to refer patients, and there was a couple of things that we believe were hindrances. First of all, the NIH and CDC advice not to use monoclonal antibodies except in a research setting had some chilling. And then unfortunately, we had a sentinel event early on, and while it's really not clear whether that was related to infusion, it had a great chilling effect. So, so as we've gone on, things have picked up. What has been most helpful what has been most helpful for us has been utilizing our public health nurses, and we actually created a telehealth clinic, and we have a couple of docs who are taking referrals from the PHNs and doing the consent and you know, the education for patients through a telehealth clinic. Our consent was also an issue early on. We thought that written consent would be ideal. I know it wasn't required in the emergency use authorization, but we thought we had a responsibility to our population to really let people know what the deal was with these drugs. The investigational nature is clearly a turnoff for a large number of our patients. So, so anyhow, we got going on it, and telephone consent really turned out to be the best course for us. We came up with an SOP that you know, is very similar to what everyone else has shown. Our space is pretty limited, so we're really only running out of one room. We have to say hats off to the anesthesia department, because they're the folks who are really running the infusions. They're also best suited to manage any ADRs, but we haven't had any ADR experience thus far, which is great. We're set up to do 3 patients daily, and our emergency department has also taken care of a couple of infusions. Turning around the room is a big deal, and we've really not been able to identify additional space. So, you know, to date, we're at nearly 50. We've used mostly bamlanivimab, the casirivimab, and demnivab as, well, we haven't used up all of our BAM yet, so we'll move on to the other one when we're out. The loosening of our use criteria really, it turns out we've really only got to about 4 days since the onset of symptoms. We're able to get people in really quick, and things are going well. I had a slide here about risk factors, which is typical, I think, for everyone's experience, and a little bit more about our about the nature of our patients, but that's not very exciting. And well, our numbers are small, but we're making progress, and this creation of the telehealth clinic has really been a great aid in our getting people in. That's what I've got.
Hey, Paul,
anybody
that's super helpful. Thank you. And remember, we said at the beginning, this is not a competition of who's got more monoclonals. By the way, I'm impressed some of you guys can say those words, because I can't. So I just say BAM-LAM and monoclonals. But what's super impressive to me is to remind myself that over, so we're talking less than 2 months, and supply coming in even within the past month, at one of the worst times to have to get staffing and care for folks who are sick in the hospitals in our state. So you all and others who are participating who didn't present today have just done a remarkable job, absolutely a remarkable job in getting appropriate medication out to folks, learning, because I have no doubt that that is actually helping our systems today when they're the most stressed that they've been. So I can't thank you enough, just on behalf of anyone I can be on behalf of, for your collective efforts and our ability to learn together. we'll find some opportunities maybe to share some best practices. Very open to everyone's thoughts and ideas about how to continue learning together and sharing information during really challenging times. But I want to thank all the presenters, all the panelists, the organizations that have worked so hard, continue to work so hard every day. You and your staff are just doing amazing things, and the entire state is thankful and appreciative of that. So thanks for everyone for joining today. If you have any questions or comments, please don't hesitate to share them with me, and I'll try to get them to the right folks. Dr. Red, thanks for what you're doing nationally. I love that chat in there about if you need additional supply, you know now where to email. That's a big take.
Yeah, that is bona fide. So please use it.
Okay, well, that's worth the price of the whole call today.
And my associate where that email maps will be very happy with me. Yeah, no, we want it to be used. I want to say one quick thing, Mark, in regards to your last comment. I said this actually at a meeting recently. Every single wind in terms of this utilization has been a headwind, but we're making progress. I mean, we had to modify both patient behavior. We've been telling people stay home for 9 months, and we had to modify provider behavior. They're new medications. I think we've done very well. This is what an exciting Zoom. It's extremely, extremely positive. It's really cool.
Yeah. Well, thank you so much. Thanks everyone again. And keep up the great work. Let us know and each other how we can help. And we'll be in touch. Take care, everyone. Have a nice day. Stay well. Wear your masks, please.